Hello everyone, this is Dr. Humanist again. Let us now discuss topic of amyloidosis. Okay, amyloidosis is nothing but extracellular deposition of amyloid proteins. Amyloid proteins are nothing but misfolded proteins. Now these misfolded proteins will aggregate in the tissues and organs, which will disrupt the architect and it will disrupt the function of that organ. Okay. So now coming to the classification, there are 5 types we will be discussing mainly: primary amyloidosis, secondary amyloidosis, familial amyloidosis, dialysis related amyloidosis, and localized amyloidosis. Okay, so we'll discuss each one in detail. Coming to the primary amyloidosis, which is also called as AL amyloidosis. Okay, it's a most common form and it is associated with clonal plasma cell disorders. So these plasma cells, they'll produce excess amounts of immunoglobulin light chain, either kappa or lambda. So this L is from the light chains of the immunoglobulin. Now these light chains, they misfold and get deposited as amyloid fibrils in the tissues. Okay, so where else we'll see this kind of picture? Like in the cases of multiple myeloma and monoclonal gammopathies. So what are the organs affected here? The kidneys, leading to the nephrotic syndrome, the heart, leading to heart failure, restrictive cardiomyopathy, arrhythmias, etc. Liver, nerves, causing peripheral neuropathy, and gastrointestinal tract also. Clinical features, as I said, renal involvement will cause nephrotic syndrome, proteinuria, and progressive renal failure. Cardiac involvement, heart failure, arrhythmias, restrictive cardiomyopathy, low voltage on ECG. Peripheral neuropathy will cause pain, numbness, tingling in the hands and the feet. Gastrointestinal involvement will cause diarrhea, malabsorption, hepatomegaly, and macroglossia, guys. Okay. Prognosis in primary cases, it is poor, especially if there is a cardiac involvement. Then the most common cause of death in primary amyloidosis is because of the cardiac failure. The mean survival of the diagnosis is 6 to 12 months only if untreated. Second type is secondary amyloidosis, that is also called as AA amyloidosis. And secondary is due to secondary causes like chronic inflammatory or infectious diseases. What are those chronic infections? Like tuberculosis, osteomyelitis, or chronic inflammatory states like rheumatoid arthritis, Crohn's disease, ulcerative colitis, or SLE, malignancies, right? This will cause what? Serum amyloid A protein, that is amyloid precursor proteins, which is an acute phase reactant. Now there is overproduction of this acute phase reactant, that is serum amyloid A, SSAA protein, during the inflammation, and misfolding will happen and it will lead to deposition of amyloid fibrils. What are the most common organs? Same, renal, liver, and spleen. So liver and spleen involvement will cause hepatosplenomegaly. Prognosis here now depends on the controlling the underlying inflammatory disease. If you treat the cause, there is good prognosis. Hereditary, now the third type, that is hereditary or familial amyloidosis, also called as ATTR amyloidosis. Here there is a mutation in transthyretin gene, guys, leading to production of misfolded transthyretin proteins. It follows autosomal dominant inheritance. Okay, so there are 2 types, one is polyneuropathy and one is cardiomyopathy. Familial amyloid polyneuropathy, which will predominantly cause neuropathy like symptoms, numbness, tingling, pain. And the second type, cardiomyopathy, it will cause heart failure, restrictive cardiomyopathy, arrhythmias, like that. And prognosis, it is slowly progressive, but nowadays the treatments are there like tafamidis, which will we see in the treatment section, which will improve the outcome. The fourth type is dialysis related amyloidosis. Okay, this happens in the patient who undergo long-term hemodialysis, like in the case of ESRD, that is end stage renal disease. Okay, which protein? That is a beta 2 microglobulin. It gets accumulated in the tissues because dialysis doesn't clear this protein. So that's why there is accumulation of this protein. Okay, so commonly it affects the musculoskeletal system. Symptoms like carpal tunnel syndrome, joint pain, bone cyst, and fractures will be there. Okay, now the prognosis can be improved with kidney transplantation, which removes the need for dialysis. And the fifth type, the last type, is localized amyloidosis. okay, in the particular one organ or tissue. For example, Alzheimer's disease, in which there is a beta amyloids in the brain. And one more example is isolated atrial amyloidosis, where there is amyloid deposition in the atria of the heart, okay, especially in the elderly patients. Okay, what are the organs affected? Brain, heart, others. Clinical feature based on which organ is affected, based on that there will be clinical features. Now, pathogenesis of amyloidosis, as we discussed, these proteins now it will be misfolded and gets converted into amyloid fibrils, that is fibril formation, and then they deposit into the normal tissues and organs, causing to cellular or organ dysfunction. Okay, now coming to the clinical features which we just discussed, renal involvement will cause nephrotic syndrome or progressive renal failure, cardiac involvement will cause restrictive cardiomyopathy, arrhythmias, heart failure or low voltage on ECG, gastrointestinal diarrhea, malabsorption, macroglossia, hepatosplenomegaly, right? Nervous system, peripheral neuropathy, autonomic neuropathy. Okay, autonomic neuropathy will cause orthostatic hypotension, gastroparesis and erectile dysfunction. Musculoskeletal involvement, joint and bone pain, okay, and carpal tunnel syndrome, like we saw especially in the case of dialysis related amyloidosis, right? Okay, now coming to the diagnosis of amyloidosis. Okay, it needs a combination of clinical suspicion, laboratory tests and histological confirmation. Okay, suppose in the cases of secondary, there is a long standing disease and then the patient comes with renal failure or any cardiomyopathies, anything, we have to suspect for amyloidosis. Okay, well, how we can diagnose is biopsy, tissue biopsy, like from the kidneys, liver, heart or abdominal fat pad, right? And we do Congo red staining. It will give what? Apple green birefringence under the polarized light. One more test is serum and urine protein electrophoresis to see the monoclonal proteins in the blood and the urine in the cases of primary amyloidosis, right? Next is serum free light chain assays, okay, like free kappa or lambda chain in the same in the primary amyloidosis. Genetic testing for familial amyloidosis, that is transthyretin gene mutations we have to see. Imaging like echocardiography and MRI to see any cardiac failure or like that. Management, coming to the management, so primary amyloidosis we have to treat like the multiple myeloma, that is with chemotherapy. We have to reduce the clonal plasma cells proliferation. Okay, so what do we use? Bortezomib, cyclophosphamide and dexamethasone. Also autologous stem cell transplantation for eligible patient, and supportive care for heart failure or atrial fibrillation, that anticoagulation you have to use, dialysis for renal failure. Now coming to the secondary amyloidosis, we have to control the ongoing inflammation or the infection. Okay, like in the cases of rheumatoid arthritis, we use DMARDs, right, SLE treatment, or Crohn's disease, we have to treat the underlying disease. So one drug is aprodicate. It is a potential drug that inhibits the amyloid deposition in some cases, that we can use. Next is ATTR amyloidosis, that is familial. So this is the tafamidis. It's a group which is the transthyretin stabilizer that prevents the amyloid fibril formation, used in both familial amyloid polyneuropathy as well as in cardiomyopathy. Other drugs like patisiran and inotersen. Okay, these are what? Small interfering RNAs and antisense oligonucleotide therapies that inhibit the production of transthyretin protein. And in dialysis related amyloidosis, kidney transplantation, where there is a no need for dialysis, and high flux dialysis. It may reduce the risk of developing amyloidosis. Prognosis, as I said, primary has not good prognosis, secondary based on the underlying cause. ATTR amyloidosis slowly progressive, but this treatment with like tafamidis, the prognosis can be improved, and dialysis related amyloidosis improved with transplantation.